My name's Tim Petheram and I'm a consultant orthopaedic surgeon in Northumbria Healthcare Trust. We've produced this safety video on implant mismatch and prosthesis verification checks. We're all humans and we can and will make mistakes throughout our practice. The National Safety Agenda of the NatSIPS programme introduces various checks and balances throughout the surgical process to try and identify these mistakes and correct them before they result in patient harm. Despite this, the National Joint Registry, or NJR, for England and Wales shows us that implant mismatch errors do occur. The commonest of these is in hip replacement with socket head diameter mismatch, and this is reported not uncommonly throughout the country. This indeed was the error that occurred in our trust, and based on this we've focused some effort into considering how we do our checks and how we can make them more robust. The following safety videos show some scenarios where those checks are carried out and where errors can slip in, potentially resulting in patient harm. And importantly, the final video will show how we've introduced extra checks to try and prevent mistakes resulting in an adverse outcome for our patients.
Okay, can I have a 50-32 socket please?
50-32, okay.
Okay, Exeter Contemporary 50 times 32 millimeters 2023.
Okay,
Okay, happy, open it please, yep.
Okay.
Pass the wash, Alan. Okay, that feels good. Just give me a standard 32 millimeter head, please.
Okay, standard head.
Got a bit of a breather here. Oh, sorry, hang on. Standard head, yep.
This first scenario will unfortunately be familiar to those who've worked in a theatre environment. Whilst a check did occur, the check wasn't quite robust enough to identify the error. We can all make mistakes, as previously mentioned, and here there was a distracting factor where the surgeon's attention was brought to the patient in front of him and a true timeout moment for the prosthesis check didn't occur. Because of this, the error where the incorrect head was selected compared to the socket that had been implanted previously wasn't identified at that verification moment, and accordingly the wrong implant was opened and implanted, and the patient left the theatre with the incorrect implant in place. We'll now go on to another scenario where we demonstrate how a prosthesis verification check should occur in a more robust nature, and how we now do this locally through our LOCSIP on prosthesis verification.
Okay, that feels good. Just let's have a standard 32 millimeter head, please.
Okay.
Okay, let's do an implant check.
Time out. Okay, so we've got 50-32 cup and a 32-0 head.
Yep, okay, 50-32 Exeter Contemporary cup. Striker, 32 millimeter zero head. Yeah, open them please.
Okay.
Yep.
Jill, phone for you. It's urgent.
Okay, sorry about that.
Yeah, let's have the head.
Standard head, Katie.
This second scenario demonstrates a much more robust implant check. This follows our local guidance which we've produced, our LOCSIP on prosthesis verification. A robust timeout occurs where all staff involved are concentrating on the implants. This includes the surgeon, the surgical assistant, also the scrub nurse and floor nurse. They're concentrating and focused on the implant. Another important feature to notice is the cross-check between the socket that's been implanted and the femoral head that's about to be opened to ensure compatibility. This is a crucial step and, if done correctly, should prevent any error from occurring. However, this scenario also shows the reality of a busy theatre. The floor nurse, who's opening the implant, gets distracted and doesn't therefore open the correct implant. Because a robust check has occurred, the staff are relaxed about the implant they're opening. This results in an adverse outcome for the patient and they leave the theatre with the wrong femoral head in place. So the next scenario shows you how we've developed our process even further to bring in another layer of checks and to deal with this unlikely but possible scenario. It's this second scenario which we feel happened in our trust, where the prosthesis check occurred, but still somehow the patient left the theatre with the wrong implant in place. Please now watch the following scenario where we demonstrate this second level of check.
Okay, can we do sign out?
Yep, okay, sign out.
Okay, procedure's been performed. Is the left total hip replacement? Counts are correct.
Yep,
Formal implant check was performed. And we have implanted a 50-32 cup,
yep.
a 28-0 head,
Oh.
and a 37-5 number 3 stem.
Right, hang on a minute.
Hang on.
Mismatch.
Yeah, definitely 32, and that's a 28-0 head. I'll just check
Can we check the
against
boxes?
the boxes.
Okay,
Okay.
let's check the boxes. Yep.
I've checked those boxes. It's definitely a 28 cup that we've put, a head
50,
that we've put in.
32, 28, 0. Yep. Okay, we need to open up the hip, and if I can have a standard 32 head, please.
Right, okay.
And then I think what we need to do is once we've finished the operation at the end of the list, we just need to sit down, debrief, talk about how this has happened and how we can prevent it happening again.
Okay.
This third scenario mimics the previous one with a robust prosthesis verification occurring, but human error resulting in a mistake where the wrong implant is opened and implanted. This third scenario, though, shows our second layer of checks that's now our standard practice. At the sign-out moment at the end of the procedure, we confirm the implants that have gone into the patient from the implant stickers, which are later to be recorded in the NJR. Accordingly, the incompatibility that would normally be flagged up later by the NJR a few weeks down the line is noticed in the operation, and we can do something about it. The team identify the error, correct it, and the patient leaves the theatre with the right implant and an adverse outcome is avoided. We feel this second layer of check is a robust way of dealing with the problem we encountered in our practice. The final thing I want you to reflect on in that last scenario is the mention of a debrief. The team have had a near-miss incident, and quite rightly they reflected that they need to talk about this in more detail later on in the day. They complete the case safely, and then later on in the debrief they're going to discuss what happened. I'd encourage all teams to consider a debrief in any situation where things don't go exactly according to plan. We'll now move on to a different scenario. This scenario again has occurred, and we've reflected on what happened and how we can improve our processes. This situation was a revision hip replacement. The attention was only to the femoral component. The socket component was left in place and had been in place for many years. Let's watch this first scenario to see what happened.
Yep, okay, that feels good. Just give me a standard 28 head, please.
28 standard?
28 millimeter standard head, 2022. Yep. Okay, open it.
This example's in a revision situation. It seems straightforward, however, that socket that had been implanted many years before was actually a 26mm inner diameter. The femoral head that went in was a 28mm outer diameter. Unfortunately, nobody noticed. Of course, the error slipped through because at the prosthesis verification moment, we have the femoral head to check, but the socket has no packaging as it went in many years previously, so there's no cross-check. To try and overcome this, we've introduced a slightly different check for more complex revision scenarios, using a whiteboard to record the pre-existing implants. Please now watch this next demonstration. Yep,
that feels good. So just a standard 28mm head, please.
Standard 28. Okay. 28-0.
Okay, Stryker standard 28mm zero head. That's what I want. We'll just double check against my pre-op plan, which are written on the board. Exeter 44-126. Hang on. It's a 26. We've got a 26 socket in. I need a 26 head.
Okay.
In this second demonstration, you'll see how we've introduced specific checks for more complex surgery, in particular revision surgery. On the whiteboard, we record what implants are already in the patient, and this then gives us something to cross-check against when we open further implants, in particular the femoral head. In this scenario, that allowed us to identify the error that occurred and again correct it before any harm comes to the patient. Well, I hope you've enjoyed watching the safety videos. Of course, importantly, I hope they've been thought-provoking and given you some ideas to take back to your own practice and trusts. Thank you for watching.